Welcome everyone, my name is Sarah and today I'm joined with Ihsan and together we will be discussing speech sounds, development and disorders. I want to first start by acknowledging the traditional custodians of the country on which the University of Sydney campuses stand and our responsibilities to respect and care for country, people and spirit. Today we will cover a range of things including the typical development of speech sounds from birth to 6 years old, as well as an introduction to speech sound disorders. We will go into depth for just a few speech sound disorders, including articulation, phonological, inconsistent, apraxia of speech, and dysarthria. Let's start by taking a look at the typical development of speech sounds. We begin with pre-linguistic vocal development from birth to 4 months. From 0 to 2 months, we begin to experience pitch shifts, buzzing noises, and vowel-like sounds. From 2 to 4 months, we also start to produce early consonants and cooing. If we move along the timeline to 4 to 6 months, we have more consonant vowel production, vocal turn-taking, pitch glides, and predominant front sounds being produced. From 6 to 10 months, we then begin to engage in reduplicated babble, which are repeated consonant vowel sequences like ma, ma, ma. We also have some intonation contours occurring, which are more distinctive patterns of pitches, tones, and stresses. We then move on to 10 to 12 months, where we produce more variegated babble, which is varied consonant vowel sequences like ma, ga, ga. We might potentially have the first words being produced in this time as well, and there are more attempts at meaningful words. If we move on to 1 to 3 years, there is more meaningful verbal output. We have more accurate motor movements, begin to develop more accurate consonants and some consonant clusters. We also begin to increase our rate of speech during this time. From ages 3 to 4, we see our more accurate speech sounds develop. According to the DEEP, 90% of children should have developed these sounds by the ages of 3 and 3.5. These include p, b, d, m, f, and s. And by the ages of 3.5 to 4, 90% of children would have already developed w, l, and y. The more difficult speech sounds are then developed from 4 to 6. So 90% of children by ages 4 to 5 had developed the sound sh, ch, j, zh, as in measure, and by age 6, the remaining speech sounds r, th, and z should have developed. During this time, we will also see the development of more consonant clusters as their speech sound production becomes more accurate. Now that we know what the typical development of speech sounds look like, let's get into speech sound disorders. First, let's start with what a speech sound disorder is. Speech sound disorders are a type of developmental communication impairment not typical for a child's age. It involves difficulty with perceiving, phonologically representing, and/or articulating speech, and it impacts their speech intelligibility, making it harder for others to understand them. There are a variety of speech sound disorders. Functional speech sounds disorders refer to those with no known cause or could be influenced by a variety of factors, whereas organic speech sound disorders are those that are developmental or acquired, including motor or neurological impairments, structural impairments, or sensory impairments like hearing difficulty. However, today we'll be going into more depth about functional and motor difficulties. Let's start with articulation speech sound disorders. Articulation refers to the motor ability to produce speech sounds by coordinating the lips and tongue with the airstream in the cheek and across the tongue and teeth. When there is a disorder of articulation, this can be presented as distorted sounds, inaccurate placement of the lips and tongue, leading to incorrect production of airflow, and a common example of that is a lisp, where there is an inaccurate placement of the tongue, leading to incorrect airflow production. So what does therapy for an articulation disorder look like? First, we start with sensory perceptual training, where we focus on listening. This involves identification, isolation, stimulation, and discrimination. Identification is where the child learns the auditory, visual, or tactile kinesthetic properties of the sound. We also often use a metaphor to talk about the sound. For example, we can call the S sound the snake sound. For isolation, this is where we try the sounds in different contexts, including words, sentences, and phrases spoken by the clinician. The child then identifies where the target sound is in the beginning, middle, or end of the word. So you might say, if you hear a snake sound, point to the snake picture. We then have stimulation, which is where the child hears the sound in a variety of ways, with varying intensity, duration, pitch, or linguistic complexity. So we might say it loudly, quietly, slowly, or quickly, or even in a tongue twister. We then have discrimination. This can be inter-auditory discrimination, which involves error detection, where we might say, tell me if I say it correct or make a mistake. Fizzes, scissors. Or error correction, where we might say, why did I make a mistake? In which the child should respond with, you let your tongue stick out between your teeth. We also have intra-auditory discrimination, where we start to shift to the child building self-awareness of their own errors. So for error detection, we might say, tell me if you say it correct or make a mistake. Whereas for error correction, we might say, why did you make a mistake? In which the child should respond with, I let my tongue stick out between my teeth. Step 2 is pre-practice instruction. So examples of cues to elicit the S sound include imitation or auditory stimulation, where an example would be, say this word after me. Use of context, so are they pronouncing it better in spread vowels, like seat? Is it better with rounded vowels, like soup? Is it better in a dental context, like tenths? Or is it better in a cluster context, like cats? And then we have phonetic placement, where we teach them a few techniques to make sure that they are physically putting their tongue in the right place. So a few examples of that would include the butterfly technique or straw technique, or using clay models. And then manual placement, where we get them to use their fingers. Step 3, and the last step, is practice. The practice hierarchy usually progresses from 1, isolation, 2, syllables, but we can also use nonsense syllables. 3, which are words, and we will have the sound in all word positions, so beginning, middle, and end. 4, which are sentences, and 5, which is on a conversational/phrase level. Now Ihsan will take over to discuss more speech sound disorders.
Now let's take a look at one of the most common speech sound disorders, phonological impairment. Now you may be wondering what phonological impairment is. Well, phonological impairment is a cognitive linguistic difficulty with learning the phonological system of a language, characterized by pattern-based speech errors. Now, pattern-based speech errors may be delayed for a child's age. Let's take a look at a few examples. Now, our first example is final consonant deletion. This is when the final consonant is deleted from a word. For example, feed would become fee. This is expected to resolve by the ages of 3 or 3.5. Moving on, we've got weak syllable deletion. This is the deletion of a weak syllable after a stressed syllable. For example, telephone would become typhoon. This is expected to resolve by the ages of 3.5 to 4 years old. Let's take a look at a few more. We've got cluster reduction. So when clusters are reduced to one of the two elements. For example, sp would become p. Again, most children are expected to produce clusters by the ages of 3.5 to 4 years old. One of our final ones is gliding. Now, gliding is a substitution of l or r with a glide, w. For example, ready would become weddy, or rain would become wane. Gliding, this may be used until the ages of 4 to 5, and even later in some immature speakers. Now, let's take a brief look at an intervention for phonological impairment. The most common and well-known intervention is minimal pairs. Minimal pairs are words that differ by one phoneme. For example, ki, she, t, or b. Being one of the oldest and most well-known contrast to phonological interventions, it is well established and used frequently when targeting phonological processes. Now, the approach uses minimal paired words that are produced as homonyms by a child. The intervention targets can be both complex or developmental, and pragmatic cues are commonly used. Let's move on to a different speech sound disorder. Inconsistent speech sound disorder is when children don't have any oral motor difficulties, but pronounce words differently due to incorrect phonological ensemble. So an example of this may be when sleep turns into swip, lip, or sip. Now, one of the most common or well-known speech sound disorders is dysarthria. Now, dysarthria is a motor speech disorder involving difficulty with processes involved in the production of speech, typically motor programming and execution. Such a condition may be a result from a neurological impairment during or after birth through traumatic brain injury or a neurological condition. Common speech features include muscle tone differences and reduced range and strength of movement of articulators, leading to distorted vowels, consonants, prosody, voice changes, and even imprecise articulation. Now, let's take a look at a few different examples of dysarthria. First up, we've got spastic dysarthria. Spastic dysarthria occurs as a result of damage to the motor neurons in the central nervous system. The central nervous system includes the brain and the spinal cord. Common symptoms found in spastic dysarthria include slurred speech, slow speech, and strained or nasal voice. We also have flaccid dysarthria. The hallmark of flaccid dysarthria is difficulty pronouncing consonants. Flaccid dysarthria can be a result from a tumor in the brainstem, a traumatic brain injury, which can occur from a fall or from a car accident, or even surgery. Yeah, let's have a look at our next one. Ataxic dysarthria. Ataxic dysarthria causes symptoms of slurred speech and poor coordination. This type of dysarthria can occur if a person sustains damage to the cerebellum. And you may not know, but the cerebellum is a part of the brain responsible for receiving sensory information and regulating movement. So any damage to this part of the brain can cause ataxic dysarthria, in which you may see slurred speech or poor motor coordination. How about we take a look at a quick example of ataxic dysarthria in a child.
Which school do you study?
SF
SF?
X
How old are you?
2
3-year-old?
12.
12-year-old. Okay. You are in hospital?
Yeah.
Which school do you study?
SF
As seen in the video, the child had slurred speech and poor motor coordination. And let's take a look at our final speech sound disorder for today. Apraxia of speech. Apraxia of speech is a motor speech disorder which involves difficulty planning and programming movement sequences. It also involves difficulty correctly putting lips and tongue in time and place. Common symptoms include dysprosody, which is incorrect rhythm, intonation, melody, or stress. Now, the patients may know what they want to say, but they do find it hard to move from one sound to another. Now, let's take a quick look at an example of apraxia of speech. So just to see the difference between the conditions. So that was an example of apraxia of speech in a child. Now, thank you guys for listening to our presentation. We sincerely hope that you have learned something today that may be beneficial for you guys in the classroom. Thank you.